All right, thanks for having me. So I'm Mark Chu. I'm one of the orthopedic surgeons here at the OTI.
I'm surgeon.
That too, yeah. So I do orthotrauma and spine. So I'll be presenting a couple proximal tibia cases here. So, what was that? Oh yeah. So,
It's going to be a rough afternoon for you.
I got you.
so I chose a couple cases just that had some discussion points. So this is a patient. She's 27. She's involved in an MVC. She was a passenger in a head-on collision. In terms of her medical conditions, she has polysubstance use disorder using meth, heroin, opioids, and then she has a history of amphetamine-induced psychotic disorders.
Great. Anything else?
That's about it.
Okay.
She has a car, so that's going for her.
Yeah, she's a passenger. So you can see here, this is a proximal tibia fracture. I just put the sagittals on the CT. There's no intra-articular component, but you can see here that it's a pretty short fragment for that fracture. So sort of want to go ask the audience, ask the panel, what would be your plan in terms of, I think the reduction is fairly simple, but in terms of how you would stabilize it, in her case, she has, multiple medical comorbidities and social comorbidities, but, does that change your management?
Kyle, when you just look at those initial films, what are you thinking? What are you seeing? What's going to match this patient's overall stature?
It's funny because you were reading my mind. I was thinking, and the easiest thing to do is put a plate on. It's pretty much reduced, and I can put the plate on. Problem is I don't know what the skin looks like, and we had a huge failure rate when we started doing the list plates of the tibia because we did it right away thinking we're doing it percutaneous, and we're like, I think the results of our studies is like 7, 10, 15%. Had to get flaps placed, rotational flaps. I don't often change what I do based on patients' comorbidities, but someone who's a meth, heroin, opioid user, I'm not sure I want to plate on it. So I would go with a nail, even though it's tougher. You have to kind of almost, you can't. You got to do a technique. I don't do the supracondylar, but I do a medial parapatellar, but you have to do it kind of an extension, and the whole problems with nailing proximal femurs, you might have to do locking screws. But I would probably go to nailing it just because of the polysubstance use.
So what position would you put the knee in to nail it? You do an actual suprapatellar nail?
No, so I don't do suprapatellar.
Because you don't like going through the knee.
I don't like going to the knee, but I go medial patella, and Max Morandi kind of gave me credit for this a long time ago, but in a way I just kind of move everything laterally, and interesting, you almost feel like you're extra-articular. Corey Collins did it as well, but the idea is that you can do it in full extension, and I believe that it's not where you kneel, so the knee pain isn't like a regular infrapatellar nail, but you're not going through the knee joint as well.
I thought Paul Tornetta's semi-extended was lateral parapatellar.
Yep.
He did lateral, and he
did
goes underneath the patella.
Right.
Lateral extra-articular.
He did a parapatellar as well.
It's lateral extra-articular.
Yeah.
Yeah, I mean, I was reluctant to, go through the knee too, but I tell you, when you've got no help, having the leg fully extended and doing a suprapatellar nailing makes it so much easier.
This is fully extended. I don't have any problem. I just don't like going through the knee, and I don't need to.
Yeah.
Okay,
Either
first off, who would consider plating this? Okay, so we got this the plate body and the patient and this patient.
Her skin was okay.
Skin is okay.
Yeah.
Just a crazy.
Just around the knee, yeah.
Yeah. No. So no.
So one thing nobody talked about, the fibula is intact.
Yeah.
And I think that if you're considering plate fixation, that's a plus.
Yeah. No, I agree.
Yeah. But on the other hand, the failure rate was a little bit higher.
Yeah.
So a couple of platers, but mainly nails. Mark, what's
Yeah, so I guess for those who would just nail it, I guess the question is how much fixation do you think you have with that proximal segment? I mean, depending on the nail, you might have, at least a couple oblique screws, maybe you could get 3, so
You could still get 3 for most of the newer nails. And
Yeah.
then you could add polar screws, so you've got pretty good fixation.
yeah. I think in looking at this fracture, I was a little bit concerned just with how proximal and just how oblique it is with like the screw or the fixation purchase there. This was a little bit, I didn't tell the full story here, so she actually has a little bit of opening, so this is more of a segmental tibia. So, so does this change your management? How would you sort of go about treating this patient?
You still want to plate it?
Yes. Yeah,
You still do?
I would plate it. I'd plate and then
I
put a nail.
taught you nothing in Houston.
Yeah, I do a plate for the proximal part, but then nail down for the distal shaft. Because you could put a plate on and put just unicortical screws just to get control over the proximal segment, leave your canal open, and then fix the distal one. Because then, I just think that this is an extremely difficult nail, and I would have to either. It's going to be hard to get both of those perfectly reduced. Unless I do it in a stepwise fashion. And so going in a stepwise fashion means I can put on the provisional plate proximally and then still put a nail down. So it's almost like a nail plate combo for that we do for the femur. So my answer is,
So,
yeah.
How are you going to reduce the distal piece?
So you just put on the provisional, like a short
Segment.
a short proximal plate. Okay, but don't,
On the
but
distal fracture.
no, a short proximal plate for the proximal fracture.
Mhm.
But where you have enough space to still do a nail, and then now it's just an isthmic or a distal shaft fracture that you nail.
Okay.
But that,
You're not going
as
to
it's
do
starting to get
any
wider,
plate
it's
for the
still a
distal
difficult
fracture.
nailing, but you can plate the fibula to get your alignment a little better.
I don't know.
Okay, so we have a couple of options. One would be to short plate the proximal segment. Would you do it percutaneously, or would you make an incision?
Yeah, I usually try to, because, she has multiple risk factors. So, with a skin incision, it'd be a lateral plate, skin incision, no spreading in the sub-Q, get the plate underneath the fascia, but really just try to keep it to like a 4 or 5 centimeter incision.
Drink here by yourself.
Is the distal fracture open?
Yeah.
It's open, yeah.
So
Small pocal.
I would do a short segment plate for the top.
Okay.
You could use a plateau plate and nail around it, or a little mini plate there. And distally, I'd open it and wash it out and probably put a plate there too. And I would take that plate off after it's nailed. I'd leave the proximal plate on.
Okay. Andy, you got help there, and you're not by yourself, so you could do pretty much anything you want.
I was just showing Steve a similar fracture to take care of where I actually did a really long anterolateral plate as far down as I could, and it didn't quite make the distal fracture, which is maybe a little more distal to this, and then I did a medial, supravelar plate
Yeah.
and overlap the
Oh.
plates.
Yeah.
And it actually worked. But I think this is all nailable. I mean, the difficulty is controlling that intercalary fragment. It's funny, we do ream nails and everything, but when I was a resident, we did unream nails and almost everything. And I got this kind of joke. I said at residence, there's no law that says you have to ream.
Yeah.
And so I would not ream that middle segment of this
Completely agree.
fracture. I'd use I think there's a big enough canal. I mean, sometimes, the lateral maybe gets a little tight, so.
And I think in the sprint trial,
But Emil Shannon stated, I know Emil's not here to speak for himself, but said a one-pass reaming
Yeah,
gives you that peridoxic increase in
Yeah.
periostic blood flow, so.
yeah. I'm just worried about spinning the fracture.
Yeah, no,
no, but even in the sprint trial, the p-value for open fractures was 0.07, so.
All right, okay, we got it all figured out. So we have no consensus on what to do.
But I think
we
even on
have a lot of options. Like Trick, I work by myself quite a bit, and so for me, I would do a supratellar nail.
Yeah.
Yeah, the upper segment I think is relatively stable. The fibula is intact. It hasn't been displaced. I don't think there's a lot of periosteal injury proximally. And then distally, I can have somebody hold it while I tap the nail. So I think if you're by yourself or you have limited help, I think that's probably the most efficient way to go after it.
Yeah.
Mark, tell us.
So I had similar thoughts as Ashraf. So I was a little bit concerned about the fixation for the proximal segment just with a suprapatellar nail. And so what I did, I just put some perk clamps just to get that reduced. And then I did more of a limited incision for an anterolateral plate, secured it in the posterior holes and then a little bit distally and then put down a nail. And so that's kind of what it looked like in the end.
Yeah, really good. Very nice, yeah. Anybody unhappy with that?
What was that?
How much reaming did you
I still reamed. Yeah, but it was an open fracture at the medial side, so I had to, expose the bone and then clean everything out. So I had a good sort of read to make sure it doesn't spin. Yeah.
If you go back to the injury film, look how small the canal is on the proximal segment. So you're going to have to, if you didn't ream that a little bit, you're going to have a hard time getting
Yeah.
a nail, across that fracture site, the distal fracture, without just, distracting everything.
Does nail size matter?
I don't think so for a tibia.
Is there any data on that? Probably doesn't matter.
9 mm fits everything.
Yeah.
And then the other question is, depending on what you do, whether it's a nail or a combination, would you allow this patient to weight bear right after?
I don't think it matters what you allow.
Yeah.
That's why I'm nailing it.
Yeah.
I'm gonna go let her go do heroin. Why
Yes,
wait?
she is. I think you might be able to coach her a little bit, but I think she's gonna be off and running.
Yeah. Yeah.
What did you tell her? You'd like?
I kind of just wanted her to just slow down a little bit, so I just told her not to, but I think she did work on it, but
Half a syringe
she's been,
of pill instead of a pill.
yeah, she's doing okay. I think I'll just skip over this part so we know that there's a valgus apex anterior
Yeah.
deformity. And then just some comments. I think we talked about positioning for the semi-extended positioning for proximal tibia fractures. We went over earlier, there was discussion about traveling traction. I think blocking screws are definitely helpful in proximal tibia fractures. So kind of to help correct some of the deformity, also prevent any toggling or any motion in the more wider proximal fragments. So you can put these blocking screws. You can even put it on both sides just to lock in the nail as well, and then supplemental plates as necessary. And then also just being aware of the nail design, so how many proximal screws you have, the trajectory, and where you're going to aim, and the length. Okay.
I just have to ask in retrospect,
Yeah.
to some degree, your plate acts as the polar screw.
Yeah. Yeah.
Could you feel like it was really necessary, or do you think you could have just?
For the blocking screws?
No, to put the plate on. Because you did everything I would have done. I wouldn't have done it through the joint, but I could still do a semi.
Oh, you're talking about instead of doing a suprapatellar nail versus an
I
infrapatellar?
was just trying to say, do you think the plate, are you glad you used the plate, or could you have considered just doing the nail without the plate?
I initially actually considered just nailing it, but after looking through the CT and sort of measuring some of the distances, I got a little bit fearful about not having enough fixation proximally. And then also it just helped with having.
You were glad even after you did it, that you put the plate on?
Yeah.
Okay, that's all I was asking.
Okay, so my second.
Any comments, concerns? Anybody not like it? I don't like the plate, but that's okay.
That was the indirect way of me saying the same thing that Tim said.
Yeah, question actually. So the distal fracture was open.
Yeah.
Helped with your reduction, helped with your alignment, rotation, all those things. Some of the data is saying open, small open for reduction. Obviously, this patient, a lot of comorbidities, but a healthy patient, good skin tissue. Would you have opened that fracture?
This is an open
Well,
fracture.
I
So.
understand. If it was not open,
Oh, if it wasn't
what do you
open?
feel about opening to get that same?
Yeah, then I usually don't try to open it, just to preserve all the periosteum, the hematoma.
Think you could have gotten the same reduction that you had?
Yeah, I think so.
I think it would have been hard.
Yeah.
I have a question really for the group. So that opening was on the medial side.
Yeah.
So how many people wash out through that incision versus make a separate incision over the anterior compartments? Like, do you extend that incision, or do you just make another one that's going to be protected with muscle?
Well, for me, I live a little bit, we injuries, and so I have a tendency to actually open them up, wash them out, probably trade safe.
How big, how big did you open how much of an IND did you do?
Just enough to expose that,
Did you
that-
work
the
through
bone.
that open wound to help? with
yeah.
the reduction?
Yeah, I just extended it approximately distally, and then
Like a fair amount. So I usually
enough to expose and
Yeah,
do
I
the
really
debridement.
like a big incision there, you want to make sure you do a really good,
Yeah.
especially in the drug.
To me, it's, I just go as big as the hematoma goes. So a lot of times there's a lot more stripping and the hematoma goes further than I think it does. So yes, I usually go bigger than I think I do. But I think any place the hematoma's gone, contamination's gone, so you gotta open it up.
But the question is, you open it up from the medial side or the lateral
So
side?
I always go from the side that it's open and I
Okay.
extend it as much
You
as I
don't
can.
have to, there's no rule that says you have to go through the traumatic wound. If it's open bone, you don't have to make that hole bigger over the perioperative. That's your point,
Yeah.
right? You can make it over muscle, get to do the same thing, and then if you have a defect when you're done, you just skin graft it.
Andy, nobody gets infected in the snow, right? So, second incision, or?
Yeah, I worry about the medial surface of the tibia. You know, it's not a very forgiving area. You think about, like I just did an open distal humerus a couple days ago, and the poke holes were way over the side, and we did a posterior incision, and just ignored the poke holes and washed out the fracture. So I think if you've got to make a, I usually give what the patient, advise you for sure, but if it's a poke hole in a dangerous place, then yeah, I make a.
I think going on the other side is wrong, so I disagree with everybody. But you don't have to go up the medial side. You just 45-degree it towards, posteriorly or anteriorly. You just have to know, what's that? Yeah, no, I don't mind,
Mark, show us where you made your decision.
Oh, for this one?
Yeah.
I can't exactly remember, but typically what I do is I extend it approximately distally enough to sort of deliver the bone, at least get,
Okay, so you would take, so Trig would make his decision like this.
yeah, no, I wasn't that, yeah, not that big.
Yeah, yeah.
But it wouldn't be just a little
So,
bit.
so would you excise this? Would you?
Yeah, it was sort of a look,
Okay, so you kind of do like a little Z and try to get rid of that so you could close it? Or open it like that so you can see both ends of the bone?
I'm really worried about that contused skin.
Yeah.
It's going to get worse before it gets better, so I kind of avoid that skin when I'm extending the incision.
Okay, so you'd take you'd probably do something.
Yeah, you
Probably more posteriorly.
go posterior.
Yeah.
Yeah, no, I think that's good.
Okay.
I like, so I agree with Andrew.
For once.
For what? All right, Mark, anything, what else we got?
yeah, I have one more case here.
Yeah.
As long as you don't put a plate on it.
No plate for this one.
That's definitely nailable.
So this one, 28-year-old male, fell down some stairs. So I mean, in the emergency room, of course, it's important to do a good neurovascular exam, check the compartments. Sort of the discussion points here in terms of the initial operative plan. Would most people, X-fix this, or does anybody consider doing an acute ORIF?
Okay, so 28, drugs, anything bad, you just fell? That's bad.
Not like the first one.
Okay.
Nothing significant.
All right, so comminuted, high-grade, interarticular fracture, healthy guy.
Yeah.
Nothing else wrong?
No.
What's the rest of the tibia look like?
Rest is fine.
Is that a part-type patella? or is it-
What was that?
The patella looks like fracture.
Yeah. I think that ended up being more of a subacute or like insignificant. Yeah.
Steve, what do you got? What do you want to do with this one? Initial manage, so in the emergency room, hurt like hell, he's got a malaligned leg. What are you going to do for him in an ED?
After my exam, I'm a little concerned about compartment syndrome, so I want to examine the guy, see what's going on, swelling and all the clinical gestalt of that. I want to reduce his joint. And probably it means he's going to need some sort of axial traction. It depends whether I'm going to do it in the ER, whether I'm going to do it in the OR.
Okay, so you pull him out and get him lined up and his foot's still white.
Yeah. Then I would, if it's still white, I feel if I have no pulse at hard signs of hemorrhage or, expanding hematoma and bruises and so forth, so I want to look for all that. And if he's occluded, then I get him to angio, or at least a CT, contrasted CT or something fairly promptly to look, see what's going on.
So you're worried about compartments and vascular?
Yeah.
Okay.
I wasn't until you said the white leg.
I didn't want to be that blunt. Trig, anything, do any different there? Try to reduce them, check their vascular status?
Nothing new.
Nothing different, okay.
Spanning X-fix, make sure his nerve actually intact, observing for compartment syndrome.
After you get them reduced, would you just put a splint on and then,
Spanning X-fix.
okay, so you take him right up to the operating room?
Yep, 100%.
So the
And get the
interest-
CT after the spanning
I don't
X-fix.
use a lot of spanning X-fixes for femurs and tibias in the knee. I use them a lot for plafons because they help me get my reduction later on. This is something that I would use because, one, it's not reduced well, and you don't want to leave it like that, and I don't know what you'll do otherwise, but this is one where there's significant potential for shortening, so a spanning X-fix is beneficial for this. Again, anteromedially with the pins, because I don't want it, thou shalt not varus. And so that's where my femoral distractor, so I think about that.
So I think for everybody, probably try to reduce it in the emergency room, temporary splint, get him to the operating room, and then X-fix. I think that would be, make sure that good vascular status and there's no expanding hematoma. So, Mark, where do we get it?
Yeah, so would anybody do any acute fixation?
No.
No? Yeah. So this patient had an X-fix. So I think just we already talked about it. You're trying to realign the joints, pull some distraction.
This looks like a Chester Ford.
Bad injury, yeah.
So this one on the left, Mark, is this, did you put some type of traction?
Yeah,
behind the X-fix?
I didn't do the X-fix here, but I think the one on the left is the intra-op, and then the one on the left, sorry, the one on the right is the post-ops.
And the skin is still good everywhere?
Yeah,
Okay,
yeah.
okay.
So I just have the CT here.
Okay. So nice posterior segment there.
That's not a Chester Ford.
No, but that
Well, there-
that medial side is hanging with the condyles, the lateral side was displayed.
Yeah, there's a split and depression.
Okay, so describe to us what you see, Mark, and what your thinking is about the fixation.
Yeah. So what you can see here, essentially a bicondylar tibial plateau fracture, and you can see here, actually on my neck. Oh, sorry. One other question: would anybody get an MRI to assess the soft tissue, the meniscus? There's a number of papers now sort of describing that.
Jim Standard would, but I'm not sure.
Does anybody else get an MRI?
Anybody want an MRI?
Probably not for this.
Looking, yeah, kind of looking for ligament injury. There is some data, there is some new data.
Yeah.
Even if he had a ligamentous injury, what, you gonna do that,
Or like a meniscus.
fix the button? I mean, I don't think so.
Whereas the final pathology, but it doesn't change my metal in there.
Yeah, I think probably, as a group, we'd say no.
Yeah, I did get an MRI, but
Yeah.
yeah. So I think just to summarize sort of the pertinent fracture points, so you can see there's a pretty significant medial fracture with a coronal split, and then there's a number of pieces. So there's sort of an anteromedial, posteromedial, and then a long sort of metaphyseal component. And then in addition to that, there's a lot of comminution sort of in the sort of the middle, sort of around the notch, and then there's a kind of a split depression on the lateral plateau as well.
The other thing is the patella looks like it's a little bit high. There may be a piece of that tubercle that's pulled up a little bit. That adds a little bit of a curveball there.
Yeah. So
All right, so how are we gonna go about this? Kyle, how do you make a determination about the incisions for your fixation based on what you see on the 3D CT?
You don't want to really know what I do with my incisions because I think it's different than everybody in the world. I go straight anterior, and if I have to go posterior, interesting enough, in fact, is they don't go on to get total knees very often. The ones that do have this posterior piece, and that's the most important part because it's A to P instability. So you've got to make sure that that's reduced. So I'll go anterior, I'll try to flip it up and go through the fracture site. And it's I'm not planning on doing a total knee, but I can get to both sides of the knee joint, lift up the articular surface. But it's that posterior medial piece that scares me. That has to be reduced and stabilized. So I might be doing a posterior approach, I
Okay,
guess.
so you'd start anterior, work your way through try to lift up that depressed segment and get as good a reduction.
Right.
And how are you going to get that posterior fragment pulled up into the construct?
Yeah, so if I can't clamp it, I don't have any problem making a separate posterior medial approach right along the tibia. And I can go back there and put a little plate, especially if there's comminution there, which I need to buttress it like with a little key plate, whatever, on the posterior side.
Andy?
I usually start posterior medial and try to buttress that fragment first, and then go anterior, but sometimes that's hard, and you end up kind of working back and forth, so.
Yeah.
Because the question, it's like the posterior medial fractures. In a trimal, if I'm going to plate the posterior medial, I prefer to have the patient prone, because it makes it so much easier,
Yeah.
so that posterior approach to the tibia is easier with the patient prone, but then you can't go around. To me, you got to fix both sides, and I'll usually, it depends on the patient's hip motion and everything as well, but usually we'll have them leg free and kind of work posterior medial and go lateral. Sometimes you have to go back and forth.
You can't change a flat tire without a jack.
Yeah.
You can't do this without a pebble distractor.
That's a good point. Okay. And what do we get?
Yeah, and then I guess another sort of discussion point is,
What you're thinking about the
yeah, so I think,
approaches.
yeah, I mean, this, I think in how I think about this, so usually for bicondylas, usually we start on the medial side. So looking at the medial side, there's a lot of comminution. Another sort of discussion point is how you can assess your reduction of the coronal split. So of course, there's the MCL there, which is in the way. And so, you can use fluoro to assess your reduction.
So you're going to make an incision, right along here.
Yeah, posterior medial approach.
Yeah, more of a
And
posterior
you're
medial.
going to reach up and clamp that because those articular surfaces
Yeah.
don't look depressed.
Yeah,
So
it's
you're
more of a
gonna
split.
clamp that.
Yeah.
Actually, I would start at the distal piece, key
Like
that
this.
first. I would key that first so you're building your proximal segment off an intact
Okay.
tibia.
So you're going to bring this over and put a couple of lag screws.
That's my first step.
Okay, then you're going to go up here and reduce that. And how are you going to hold that? A little tiny T-plate or something like that?
Yeah, posterior
Okay.
medial plate.
So now you've got the medial side. And then lateral, what do you got for lateral?
Yeah.
You're going to make 2 incisions.
Yeah, so I guess the first thing, getting contralateral knee x-rays can be helpful. So the first thing I did was like Trig said, I sort of just provisionally reduced that long metaphyseal fragment, and then I got the reduction of the joint, and so oftentimes I use fluoro, but sometimes if I need to directly visualize it, make a little longitudinal split in the MCL. And then in this case, I sort of put a couple leg screws A to P to try to compress that split. And then,
Side, do you ever do a submeniscal arthrotomy, or do you judge your articular reduction by the cortical, the key, cortical, key there and then fluoro, or do you ever do a submeniscal arthrotomy?
yeah, personally, personally I use fluoro just because more often I use fluoro, but occasionally sometimes might need to take a look in the joint if having trouble. That one, I think I think that might have been I think that might have been a suture anchor. I think part of the MCL, I think there's a little bit of an injury, so I wanted to tack that down.
Oh,
Yeah.
you had a couple.
For the
yeah, a couple
MCL.
of them up here, okay.
Yeah, yeah.
All right, so you got any
So-
criticisms about the approach medial?
Yeah, no, the approach medial is fine, but you can go in here, do submeniscus, so you can see the whole thing, so I don't rely on fluoro as much, but you can do exactly what you're doing, and then if you have the anterior approach as well, you lift it up and you can actually see it. I saw that you had your femoral distractor on it, so that's a
Yeah.
good point. I saw the little ring, and so that's critical because it opens it up. If you don't have it opened up, you can't see it.
Yeah.
Right there.
Yeah.
Okay.
Yeah, that's a good point. So distraction there. So after getting the joint right, I kind of pieced together all these separate fragments to get it back into alignment. Personally, I thought that the posterior medial piece needed a buttress plate, so I added that basically this T plate in the back just to support it, and then a long medial T plate as well. So this is sort of the construct on the medial side. And then for the anterior, the lateral split depression is pretty standard. You can see in the middle X-ray there's some depression. So using bone tamps and then putting a number of K-wires and an anterolateral plate.
Meniscus caught in the graft.
Yeah, I think so. I think I had to fix it and put some sutures in. And then the rest is pretty standard. I put some rafting K-wires in, and that's sort of what it ended up looking like.
I think that's a good job. Yeah, really good job. Yeah. I like it.
Okay, I think we talked about everything, so I'll leave it at that. Okay, yeah.